question is, I've read about some other sort of treatments. For example, somebody I think is looking at this in lung cancer, where they've got some kind of product that enables drugs to penetrate deeper into the cell. So my question is, if that was the case, and we could find such a vehicle to transport imatinib deeper into the cell, is it possible that it could then be, that imatinib would be effective against some of these other exons that are actually deeper in the cell, where currently it isn't?
That's a very interesting question. I think in the case of imatinib and where it's most active in GIST, if you look at KIT, is the different parts of the KIT receptor do different things. So if you have a mutation deeper down in the cell, then that's the ATP binding domain, and that does something different. That's where energy is transferred, and that's where the signals are coming from. And imatinib, when there's a mutation there, then the action of imatinib in another part of the molecule doesn't have the same effect. I was trying to find some pictures of crystals because sometimes it's quite nice and people show models of where imatinib sits. So I don't think that getting more imatinib into the cell would make a difference. The thing with sunitinib is that with some mutations, when you have a mutation, the shape of the protein changes. So it may kink or it may open up a pocket where the drug can go in. And with some of the mutations, imatinib can't interact with the receptor as well as sunitinib can. And that's, I think, thought to be why with some mutations imatinib doesn't work quite as well. I think imatinib has a chance of working in all GIST, even in wild type, the patients where there isn't a mutation. That probably isn't because it's acting on KIT, which isn't a target. It's probably because it's got some other proteins that it's targeting. But I think in the case of mutant KIT and the secondary mutations, I don't think it's a drug penetration problem. I think it's just that it's a bit of the molecule that's doing something else.
Thank you. My second question relates to this thing about mitotic counts, and there being some question about the thickness of the tumour sample that was used. So it might be been classified as having a high mitotic count, but in actual fact it's because there was just a thicker slice being investigated. Obviously we've got some patients who've been told they've got high mitotic counts, and I think as a result of that, even though they may have had their tumours removed, they are then recommended to go on to adjuvant therapy because of the high mitotic count. Would it be advisable to have a sort of a second opinion on mitotic count in that sort of circumstance? And should they, is the best place to have a mitotic count done one of the 6 specialist sort of GIST pathology labs rather than somewhere locally in their hospital?
Well, I can see I might have opened a bit of a can of worms with this, but I think my point was not that we should be reviewing these, but just that if a decision is being made on the basis that this is 5 mitoses, and it's a decision, a sort of no treatment decision, and it's right on the border, then I'd be I'd be going, well, that could be one either way. This is an example that it might be twice as thick. They don't cut them twice as thick. They might be slightly different. And so it might be a difference between 5 and 4. And if that was going to be a no treatment decision, then I'd want to look at the whole picture quite carefully. So I'm not suggesting that we should have to have all of them recounted, because the pathologist would be down on me like a ton of bricks if I suggested that. But I'm just saying that these numbers sound very clear-cut, but actually it's a more complex process. And we can't just dial a number and go, oh, 4 you're out, 5 you're in. If you were on that border, when I see patients where it's on the border like that, then I'm going, well, how big was the tumour? how ugly did it look? How was it? You know, look at the whole picture and not hang everything on one number, which could be a little bit dodgy. It's just that we always think we've got a number, that's it. And I was just wanting to say that these numbers aren't absolute. And that's probably not terribly helpful, is it? Yeah, in the middle.
I'm thinking Jane might have been thinking of me when she just asked that. Because, so therefore I ought to rely on the fact that my mitotic count of 67 is quite high.
Yes.
And therefore I'm on adjuvant therapy. And my question is, the last slide you showed said that the cancer drugs fund is approved Imatinib in the adjuvant setting for 3 years. I'm coming up to the end of 3 years. Who do I need to persuade? How do I need to persuade them that they should continue giving me adjuvant Imatinib?
Well, I don't think that you will be able to persuade them because there is no data that giving more or longer is better. I mean, and this is a slightly frivolous thing to say, but if you want to do that, probably the best thing to do would be to go to a Scandinavian centre and join that trial, because at 3 years you could be randomised between continuing or stopping. But that's the only way currently that you're going to get treated for beyond 3 years, because there is no data to show that there is any benefit from going beyond 3 years at the moment.
Okay. I'll ask you another question privately, but
Okay. Was it a question? Yes.
I was just going to say, we were told, without mentioning names, yesterday by our oncologist, similar situation to you and your husband, just coming up to 3 years, and there is evidence of reoccurrence after stopping this type of therapy after 3 years. There are patients with reoccurrence evidence.
Well, there will be. Patients will recur. Whether or not they're on the drug, there will be some recurrences. And we've certainly, what we're showing on those curves is that we've delayed recurrence, but we've also showed that we have improved the cure rate. So, you know, I think that it's true, it's possible to recur beyond 3 years, that is true, but we don't know that continuing the drug for longer is going to give any more benefit than 3 years treatment.
so therefore, if, say for me, for example, and other people in the same scenario as me, that it recurs after coming off it,
Yes.
you'll then put back on it and the 3 years starts
Yes.
again.
Yes.
But the 3 years wouldn't start then. If it's come back, then you'd
Well,
be
no,
on
it'd
it
be metastatic,
continuously.
Yeah. Yes.
Two questions really. Very simple one. Just explain to me what the difference between a GIST is and an advanced GIST.
Difference in just
Yes. Yes. So your first question was about
GIST versus advanced GIST. That was my fault.
Advanced GIST. So the original license for Imatinib was for the treatment of advanced GIST. So that was locally advanced, so too far, it's localized but too far advanced to be operated on, or metastatic and therefore inoperable. So advanced GIST meant inoperable GIST. Okay. And then your question is that after a big tumour, but if it's been free of disease for a long time.
Well, big tumours tend to relapse earlier or recur earlier, don't they?
They do, but as you saw, the big tumours, most of the relapses occur in the first 2 or 3 years, and then beyond that, that's much slower. So there is, I can never say it won't come back, but I think the more time passes, the more relaxed we get about it. That's what I tell my patients. Yes?
What recommendations would you give? You know, you were talking about 3 monthly to 6 monthly scans. I finished my adjuvant therapy, it's coming up for 9 months now. I was on it for 3 years. So I had my first scan after 3 months, and now I've been moved to 6 monthly scans. So I'm coming up to 9 months at the beginning of May. Just getting anxious obviously from the scan, but would you recommend moving
I think we take into account if we're treating people with advanced disease, so if there's something that you can measure and something you can track and monitor, I think we look at the site and the mutation status. If you've had a good response, patient's well, you may think about moving to 6 monthly scans quite early. As I say, our practice so far has been to do that after about a year, but that's a local practice, and as I say, NICE want us to assess tumour control every 12 weeks. Now, NICE don't mandate scans, and so we've taken the view that if we're seeing people there well, we also do blood tests. We're interested in whether a particular blood test can be used as a biomarker in GIST, and we've presented some data 2-3 years ago suggesting that that can be informative, although it doesn't completely replace scans. Then under those circumstances, we think it's all right to do a 6 monthly scan, but by then people are used to us and they know that if they're concerned they can come back sooner, and we look at the bloods, and if we're concerned about them we may bring a scan forward. So I think more favourable settings you could do less frequent scans, but in people with an exon 9 mutation and a small bowel primary, you might be a bit more cautious about going to a 6 monthly scan, I would suggest. I don't know what you do in Sheffield.
Well, I think you were partly talking about the adjuvant setting, and that we don't have data on that, and I tend to therefore treat people in the same way as we did on the trial. I'm trying to remember the schedule now, but I think it's out to 5 years, and then we go annually with the scans. Yeah. So it would be, after 3 years, it would be probably, I would do it a couple of 4-month ones at 6 months, and then annually after 5 years. So, but it would be tailored a little bit to the actual risk profile of the individual patients. Yes?
Hi. Have either of you got any patients on Imatinib? And if so, have you had any good results from it so far?
I've only got one patient on Imatinib, and he's only been on it for about 3 weeks, so I can't comment on that. And I think the other thing I would say is that the sort of nature of the situation at the moment is that we've got fantastic treatment with Imatinib, we've got very good treatment with Sunitinib, we've now got regorafenib, so we're really only giving Imatinib in our practice to people who've really run out of options, and those patients have got tumours which are starting to show other mutations, they're starting to behave, so it's actually not a fair test of the drug. I really wouldn't want to draw any conclusions from whatever happens to those patients, because you know those tumours are already starting to behave very badly, and it wouldn't be a fair test of the drug. We really need to get proper trials to look at it in a defined setting so we know what we're looking at. So anecdotes about somebody who does well, somebody who does badly, I really think we have to be very, very cautious about.
I've been on it for nearly 3 months. I've got a scan in a couple of weeks. I mean, the side effects were quite horrendous at the start, so I lowered the dose, and it's a lot better now. But it would be interesting to hear about somebody else. I did choose it over regorafenib because of the side effects, but at least I've got that as an option to go on to if this doesn't work. But
have you got any experience with Imatinib?
I haven't got any experience in terms of patients on the drug, but we do have the first-line study open, so patients with GIST that can't be removed surgically. It's a trial randomising patients between Imatinib and Imatinib. It's quite a hard sell to patients because there's quite a lot of screening, as any of you who've taken part in trials know. You've got to have a scan, and there's an echocardiogram because we don't want to damage people. So there's quite a long workup. I think the fact that it is in a first-line trial suggests that the manufacturer is reasonably confident that it's an active drug, and the earliest studies suggest that. But unfortunately, I can't comment on individual patients because I haven't treated any. I think the other thing that I was thinking about recently and also when preparing the talk, is that the group of patients we have whom we consider for first-line studies is changing. Because so many people are on adjuvant treatments and doing well, or are being scanned and we're picking up very small recurrences. Now, these patients may not be eligible for a first-line study because randomizing something against imatinib because they're already on imatinib, or they're staying well for a long time, and that's fantastic. But I think we've now got this period of time where people have been on adjuvant imatinib for 3 years. We've got a huge cohort, and we're not picking up the recurrences in high-risk patients who are not on any treatment in our screening program. So either we've got our high-risk patients on imatinib, or we've got the patients who present with a big tumour and a gastrointestinal bleed, or are in a lot of pain and want to start something today and can't tolerate or may not be well enough to wait 4 weeks for all the screening. So I think actually there's possibly a little bit of a gap in our recruitment to these trials, and that we'll see how over the next 2 or 3 years that balances out. But just if you stop seeing lots of results coming through, it may just be that worldwide the spectrum of GIST is going to change, and that's just something that, you know, if people are well, that's brilliant, but we may not be able to answer some of the questions that we have and you have as quickly as we'd like.
Sorry, just about scans, I get slightly paranoid about mine. I had a small GIST, 38 millimetres, taken off the top of my stomach in November 2011. It was a 3-month scan, and then a further 6 months. Then my consultant said annually, and I'm just about to have a second annual one in August. As a profession, do you use the same criteria for assessing the
Sorry, could you possibly speak up?
This is a question about frequency of scans after removal of a GIST.
So there's no medication. Fingers crossed, I might be quite fortunate. My score is 16%, the very possibility of a recurrence. So I hear people talking about 6 months, and so on. But after a period of 9 months, the second scan was done, and then it was annual. It's going to be annual again after that. Would you say that was, as a profession, would you all decided on that, or was it just my consultant's opinion? Should I seek a second opinion, perhaps? Everybody's different.
Yeah, I think we're fairly conservative in Leeds. I'd be interested to know what Sheffield does. Novartis sponsor a roundtable expert meeting which publishes an outcome every few years of the management of GIST. And one of the things that contains is a recommendation on frequency of scanning. There's also a European document, there's also an American document, and there's also local custom and practice, and there's also what adjuvant studies do. So there are lots of different sources of possible schedules, and as you suggest, they're not all the same. I think that what we've done in Leeds, and I think is a reasonably rational approach, at least I hope it is to look at these and look at individual risks. So we do a risk stratification on our patients, and we assign a scan schedule depending on whether someone's low, medium, or intermediate or high risk for recurrence. So people who are at higher risk get more scans than people who are at lower risk. And that's about not making people too paranoid, but also limiting the amount of radiation that people have. To put the risks of radiation in context, the germ cell, the testis cancer community did a follow-up schedule trial where they were comparing outcomes in people having 5 scans, which was the standard at the time, against 2 scans. So they were worried in these people, the vast majority of whom were cured, about doing 5 scans. Now, some of the schedules recommend 10, 15 scans over a period, but the potential radiation damage is cumulative. So if you're looking at people at a low risk of recurrence from GIST, you may actually be causing more problems in the long term, which is hard to quantify, but you can get figures for that by doing a lot of scans.
Because it classed as intermediate, but
So in Leeds, I think our intermediate schedule is 3, 6, 12, 24, 36 months. So we do 5 scans over 3 years for an intermediate risk, and we do 4 scans. But you know, that's what we've done based on looking at the curves for recurrence, depending on the risk. Also, how easy it is to look at the area. Different people will do different things, and you can always ask for a second opinion and go and be referred to someone else to discuss your concerns. Penella, what do you do?
Okay, let's take another question.
Yeah.
Sorry, really a continuation of this question. Would the decision take into account the age of the patient? Bearing in mind, I mean, someone in their 70s, if they have sort of scans every 6 months, something else would probably kill them before they get any damage from the radiation. But if you're talking about someone in their 20s, you're looking at a very different scenario.
Yeah, treating radiation sarcoma in a 90-year-old, not fun.
Well, I think my view is that, you know, we've looked at all the different risk models, and age isn't important here. That it doesn't influence the risk of recurrence, and that actually it's not as though we're going to be discussing a treatment that we wouldn't give to somebody who was 80. No. We give patients of any age Imatinib, so therefore age wouldn't actually come into my calculation on that.
Okay. Mine's sort of similar sort of question. I hope it's not too trivial. I'm one of the lucky ones because I had just 4 years ago, and I had it removed by surgery. And I had to have no further treatment. And I went for, I think it was 2 scans and a couple of endoscopies on the stomach. And it was paid because I had medical insurance. But after that, of course, the medical insurance wouldn't pay. And so I asked to go onto NHS. And I was told, you don't need it, you're cured. And I was a bit concerned that I'm no longer, I know it's 4 years.
Is that a surgeon or an oncologist?
I ought to still be under the umbrella of having checkups.
Well, I think that, you know, the difficulty is that the very low risk, and I showed in my early slides, the vast majority of patients are like yourself, who've had a low risk tumour, have been completely resected, and most of those patients will be already cured. So I think it's quite difficult to then start introducing a lot of monitoring for them. So in one sense you're talking to the wrong people, because we see high risk patients and we see patients with advanced disease, whereas the surgeons see patients who are cured. They had low risk tumours and the chances are that they're cured, and so the amount of imaging that's done is done for a couple of years and then they leave that. I think the important thing is that you and your GP are aware that you've had this problem in the past, and if you had any symptoms suggestive of further problems, anemia or bowel problems or weight loss, you and your doctor both would go, you know, there was that problem, it might have been 8 years ago, but we need to just be aware of that and that any symptoms are investigated with that in mind. So I think that you know, regular scans aren't going to prevent problems. The important thing is if some symptom develops, to investigate that and be alert to the fact that you've had that treatment in the past. So I'm quite aware that, Barbara, thank you very much, that we don't want to hold you up. Thank you very much for your questions, it's been very engaging.